is not what I need. Yes, excellent. Okay, thank you so much for inviting me to speak to you today. This has been my first ever attendance at a BNPA conference, and I've really enjoyed the program so far and this interdisciplinarity, so I think it's an excellent conference, and I should have clearly attended much earlier. I was also reflecting on why I never attended before, and I'm obviously not a neurologist, I'm not a neuropsychiatrist, I'm a neuropsychologist, but there's clearly plenty of neuropsychologists here. So my main conclusion is probably it's related to how stroke is organized, quite separately from neurology, and actually quite separately from ABI as well, despite obviously being a neurological condition and very obviously being an acquired brain injury. Anyway, this session is therefore going to focus a little bit on stroke, and more specifically on neglect, but more broadly, stroke is often seen clinically as this acute disorder that gets acute treatment, and then people leave out of stroke services into primary care pretty much. And what that's meant is that many, many people feel completely abandoned by clinical services after they leave hospital, because even though it may be an acute event, it is also for many people a chronic disorder that they live with for the rest of their lives. Unsurprisingly, perhaps to us who work in this area, is that cognitive impairment and psychological change is huge in stroke. And actually, if you look at the numbers and all of these prevalences, they always matter and kind of differ depending on how you measure things, but you can pretty much assume that everybody you see acutely will have some cognitive impairment, and actually quite a large proportion of people will continue to have cognitive problems long-term after stroke. In addition, the prevalence of things like depression is much higher than in the non-stroke population. And so all of that put together will mean it's no surprise to you that actually managing people's cognitive and mental health is the most reported unmet care need within stroke. That got reflected recently in priority setting exercise for stroke research priorities, with the top two priorities being named as mood and cognition through the James Lind Alliance partnership. Anyway, I'm going to focus in just on neglect today. For some of you, it may have been since your undergraduate days that you learned something about neglect. For some of you, this may be your daily practice, but I'm hoping to address all of you by just starting off with a definition that works quite well. If you look at it as a higher order, supramodal attentional syndrome, really characterized by this inability to orient, report, or respond to stimuli in the contralesional space, not attributable to elementary sensory or motor deficits. It matters because it's very much related to poor outcomes. Acute neglect predictive of long-term poor outcomes in a range of things, but probably most known to you, things like return to driving, activities of daily life, but also higher rates of anxiety and depression in people with severe neglect and worse quality of life. Notably, all of those things, often all of these studies, most of them will control for things like stroke severity and lesion size, so it's really quite specific to neglect and not just, oh, you have had a more severe stroke, therefore you will have poor outcome. The way to measure it is often looking at it in terms of spatial bias and how far it is. And I kind of put this on here. Often when we talk to undergraduates about it, you kind of think, oh, it's missing half of the world. But you're not just missing half of the world. That's kind of a variable amount of how much you're missing, depending on your attentional load. So this is old work by Masood Hussain, kind of showing that the higher the attentional load, the more actually people are biased towards their ipsilesional side, and the more they miss from their contralesional side. So the way it's then measured is through the extent of this kind of spatial asymmetry, like things like center of cancellation, where you kind of compare how much people are exploring one side or the other. So I thought I'd start with a case example, and this is a patient with thanks to Professor Jane Riddock, Emeritus Professor Jane Riddock, who gave me this video, and it's an old video, so the quality is not great, but it's really worth it as an excellent illustration. So this patient has just done this kind of Albert's task, where she's missed some elements on the left, and what we're going to do is show her what she's missed and go through. So you'll see what I mean with, actually, it's an attentional disorder. hopefully.
Just put your hand. Put that up there.
So at this point, she's like 7 years post-stroke. She's very aware she's got neglect.
Turn round now. Can you see any that you've missed?
Yes.
Can you point to them?
1, 2, 3, 4, 5, 6.
Yeah.
7.
Okay.
1, 2, 3,
So.
4, 5, 6, 7.
Put your finger on one of them. You got it?
Yeah.
Okay. Keep your finger on it. Keep your finger on it.
So note her attention's on it, her eyes are on it, everything's on it.
Okay, so you can still show me it, yeah? Which one you missed,
Yeah.
Okay.
Her eyes have not moved from away, so she is able to see it.
Take your hand away. Look at me.
Remove the attention.
Now show me it.
It's disappeared. It was somewhere around there. It's unbelievable. It's like a joke, this, isn't it? It's amazing. It's like a joke you play on the kiddies, isn't it? Really, it looks as if, makes me look as if I'm daft, doesn't it, Jane?
No.
It's getting better, Joe. It's just...
Because there was 7 of them. Oh, here's one. Is that one?
Is it?
I think it is. Is it one? No, it's not. No, it's not. No, it's not.
You could just see where she's exploring, right?
Move them round again. Tell me when you start to see the ones you've missed. That's it.
Where are the other 3?
One, 2, 3, 4, 6, 7.
What about that?
Yeah, so the reason I like this illustration so much is that it shows you that actually when your attention's on it, you can stretch. It's like a spring, you know, you can stretch quite far, but then as soon as you kind of remove it, it just kind of collapses back and everything moves back to that side. So it's definitely something that can be stretched. And I think this video shows it so nicely. Oh. Okay, so I'll talk about 3 sections today. So measurement, mechanism, and recovery. And so in terms of measurement, there's probably 2 points we're going to make, that it's heterogeneous and that we should be actually doing some objective testing to detect it. When we say it's heterogeneous, you'll find lots of things in the literature about lots of different subtypes of neglect, and I'm only going to focus here on one, which is the difference between egocentric, so with respect to your own body, neglect, and allocentric neglect, which is kind of missing half of an object, irrespective of space, actually. So it's you're having this attentional bias within an object basis. So the way we measure this in the Oxford Cognitive Screen is using a heart cancellation. And the task here is to cross out the hearts that are complete, which means that you're not supposed to be crossing out the hearts that have got a gap on the left or the right. And so the kind of typical profile here then is, you know, someone with egocentric neglect won't cross out the whole page. Someone with allocentric neglect may well be crossing out all of the page, but systematically also is crossing out hearts with a gap on one specific side, because to them, that looks like a complete heart, because they are neglecting half of the object. Those 2 things actually dissociate. So we did some earlier work on this and found that in a large proportion of patients, you find patients obviously that have no neglect, that have purely egocentric neglect, that have purely allocentric neglect, and then that have both. So here, these kind of asymmetries give you the severity range. So 30 is really highly severe neglect, and 0 is none. So everybody who's kind of out there has got some level of allocentric neglect. So they have no egocentric asymmetry. So they didn't do any of that, you know, more on one side than the other, but they did cross out more gaps on one side than the other. And then you have the patients with pure egocentric neglect that make no allocentric errors whatsoever. And again, they range from left-sided neglect to right-sided neglect, which is probably something else that I'm going to note in a minute. And then you have these patients that have got both. And if you go back to your old lecture notes from in your undergrad, that shows that this is actually a double dissociation, right? So you're able to find patients that have one but not the other, and the other but not the one. So when we're actually measuring neglect, we should really be doing performance-based measures, and that doesn't always happen in stroke services. So often the main measure that gets taken is the stroke severity scale from the NIH, which is pure observation-based. It's got a series of items that the clinician ticks afterwards to kind of reflect the severity of the stroke. And one of the items is on extinction and inattention, where the clinician is asked to judge, is there no abnormality here? Is there some inattention, or is it profound hemi-inattention? And so we did a study to kind of check how well do these kind of observational judgments relate to actual neuropsychological based testing. Not very well is probably the summary of that. So to explain the graph, what's going on is in red are the cases that were deemed to be no neglect by just the observation, but were deemed to be neglect based on cancellation measures. So you see a lot of red. So those are all cases that would have been missed in the observation measure. There's a clear relationship in that fewer cases are being missed, the more severe the neglect is. So if you've got very severe neglect, you probably have seen these patients who completely turned all the way in their bed, focusing on their ipsilesional side. Those you will definitely detect, but the kind of not so obvious cases, not so much. We also kind of found that this, one or two doesn't seem very meaningful at all, because people just seem to be randomly ticking. That was not related to the severity of neglect. And we also found expectation biases, because you've probably all been taught that neglect is a right hemisphere deficit, and so you see a lot more people being judged to have neglect after right hemisphere, even though quite a lot of the acute patients with left hemisphere deficits also have neglect, and actually quite severe neglect. It recovers better, it doesn't last as long, but in acute settings you see a lot of right-sided neglect after left hemisphere lesions. So based on a systematic review, the EAN guidelines for rapid screening basically concluded we need to be doing cancellation tasks as part of your first screening tool, and you can't just rely on observation. So that was based on a lot more than just our study, obviously. Okay, in terms of mechanisms, I talk a little bit about pre-attentive processing, given that this is a session on awareness, and this always fascinates people, and I'll talk a little bit about the neuroanatomy. You probably all have seen this, I imagine. It's a classic case that brought neglect into the fascination of many people, where you had a patient who reported, when asked about these two houses, they said, I see no difference, they are the same to me. But then when asked, which one would you prefer to live in, they would more systematically pick the one without the fire coming out of it. And that was taken, and in many undergrad lectures will have been presented as evidence for pre-attentive semantic processing, so processing of unattended information. A hugely influential case study. Now remember, this is a single case. They did it 17 times. There was also hemianopia present. Not sure if the semantic manipulation is meaningful, because there was no control of a non-semantic one. So there's lots of things that maybe were unclear based on that initial study. So we set out to do a registered report study with Cortex, where we got all of the methods registered first. It makes for a really difficult thing to read, is all I can say. But I'll summarize it here. Anyway, we had more than just the houses images, and the task was still the same. What would you say, is there a difference here, and then which would you prefer to have? So like I said, there was some other stimuli there. We included 54 patients, mainly acute patients actually, because we needed them to have neglect severe enough that they would miss half of the object that is actually being centrally presented. So 21 stroke survivors with neglect, 33 without neglect. And actually it worked quite well, in the sense that of the 21 with neglect, 14 of them did consistently say they saw no difference. So they said, yeah, these look the same to me. So it seemed that the manipulation and the severity of neglect was severe enough to kind of create that, yes, they look the same, even though, as I say, centrally presented house. or TV or whatever. Then the next question was, which one would you have prefer to have? Actually, on the first bit, 8 patients that did not have neglect also consistently said they were the same. So that we were not expecting. We initially weren't planning to run controls because all of these studies are typically done just with patients with neglect. That was our initial plan. We got asked to please also include patients without neglect, and actually the side effect of that was that we found several of those that consistently said, yeah, no, they look the same. Of those who said they looked the same, so the 22 patients basically, right, the 14 plus the 8, 6 systematically had a bias in terms of preference. So if you look at it, that's kind of saying they would prefer the non-burning house, they would prefer the non-shaded house in quite a lot of percentage of the trials, but only one of those had neglect. The other ones were of the 8 that had no neglect. We didn't find this kind of difference between whether it's just shaded or burning, so there didn't seem to be this very semantically driven effect. So we conclude from this kind of findings that actually, however fascinating it is, most patients don't show this kind of evidence of any kind of pre-attentive processing. But we did replicate it, again, in a single case patient, as well as those 5 without neglect. Right, briefly about the neuroanatomy. You've probably been taught at some point it's a right parietal, posterior parietal cortex issue. Most of us have moved on to say that actually doesn't work. We've done a big systematic review on all the lesion symptom mapping studies we could find at the time, which is not that old, so 2 years ago now we published it, well, 3 technically, 26. Which looked at all of the lesion symptom mapping studies we could find on neglect and actually find that there's a huge heterogeneity in the regions being reported. This is just on egocentric neglect. There's lots of subtype variations as well. It's basically very, very messy. We tried to figure out a way to split these up in terms of quality of evidence, because some of these 72 studies had very small sample sizes, some didn't control for lesion volume, some didn't control for the vascular territory bias. So there was lots of ways we tried to kind of think that maybe some of the heterogeneity could be explained by methodological differences. But actually, even when we kind of took the ones that were quite similar and large samples and had done what we would consider, high quality research, there's still a huge inconsistency. So if it is distributed and if it's not really specific to an area, then we should look at it as a disconnection syndrome. Other people have done work here as well, obviously, so I'm just going to briefly present some of our work here. So we took 480 acute stroke lesions and neglect assessment data and ran through voxel-wise mapping, tract level disconnectivity, and network level lesion mapping. And so it's published, so you can go and read it. And for the sake of time, I'm just going to emphasize that actually what you find is that you have these non-homologous neglect areas. It's not the same in the left as it is in the right. You do get to differentiate this kind of egocentric, allocentric. They are overlapping networks, but still distinct. It's not as simple as thinking, oh, the egocentric will be dorsal pathways, the allocentric will be ventral pathways. That doesn't seem to map. And the disconnections give you more explanation than the focal lesion. That's probably all you need to know about that. In terms of recovery, classic picture of somebody doing self-portraits over time, clearly showing improvements over time and getting better in terms of the bias. We, again, ran a systematic review. This was on the natural recovery to kind of understand, what is the recovery trajectory. The main point to see is that you see this really steep recovery in the initial stages. So initial neglect improves quite a lot, and then kind of still improves on the longer term. So you still see additional recovery by 6 months, but at that point, usually kind of plateaus. So this was, all in all, 27 studies, All in all, 839 stroke survivors that had at least 2 points of measurement of neglect. So that's how they got included into the systematic review. Again, different studies will have different sample sizes, etc. Probably the takeaway messages is that it recovers quite well in most cases, but 40% of patients did show persistent symptoms. So that is a lot. When we looked at in our own data, we actually found only about 30% patients had long-term symptoms. And the thing that was cool to see is that when we looked not just at recoveries, like binary, you have or you have not got neglect, like you're within or without cutoff, you looked at just the severity, and you could see quite clearly that even those who still had neglect 6 months down the line, the severity was a lot less. So there was improvement for everyone, kind of proportional to the deficit size at the start. Another thing to note is that often neglect does not occur in isolation. So this is just if you look at the attention domain and look at co-occurring deficits, then the biggest one is with executive dysfunction, which is noted alongside attentional dysfunction, but also memory impairments, number impairments, to a much lesser praxis, but nevertheless you can see that patients often have not just neglect. That actually came out quite nicely in a recent study we've just published in Imaging Neuroscience, which is mainly about imaging, but actually the core of it is behavioral, looking at whether you get these kind of profiles of combined deficits. So we try to make latent class models to see what are these classes of combined deficits that we see. This is a large collaboration, so we had over 2,000 data points in here. Lots of neuroimaging for the people who are into neuroimaging. I'm going to skip. Sorry, there's probably loads of you. It's published, go and read it. The key bit of the behavior is that, there are these patients, so, if you looked at the classes, you could see one of those classes that very much looked like neglect only. So in the gray curvy bit is the average of everyone, so all the 2,100, and then you have the profiles of this particular class, which shows a lot less impairment in any of the other domains, so naming, semantics, number calculation, but much, much more highly impaired on the cancellation, and in particular, in this case, egocentric left neglect. So clear, nice case of neglect only. But similarly, many cases of people who also have reading deficits and naming deficits and visual field deficits, or seem to have a lot of higher levels of impairment throughout, and then mainly also have some of the neglect, or actually have got quite a lot more deficits. So you kind of see it's not that straightforward that people just have neglect and there's nothing else going on with them. As a final point around recovery, this is a separate study from us where we looked at brain health markers. So instead of looking at the lesions on the scans, we looked at the GCA ratings on the scans, so atrophy ratings. We also had white matter disease ratings. However, this was on CT, so it's a lot harder to do. Nevertheless, we kind of found that you see this brain health moderating recovery. So if you look at long-term, so in long-term 6 months, so it's not that long-term, but 6 months deficit and the relation to atrophy, you see that the worse the atrophy, the more likely people have persistent problems at 6 months. And actually, when we broke it down, this is particularly the case in the attention domain. So this is simple, people who had a persistent impairment and neglect versus people who recovered. And then on the y-axis, their atrophy severity. So people with persistent impairment just had higher atrophy ratings. All of that, to summarize, if you didn't listen to me for the last bit, you just have to remember these things. You should measure. Cancellation should be your first-line screen. There's a lot of going on in terms of distributed networks underlying neglect. There's a steep early recovery, and those who don't recover still improve. Probably the most clear takeaway is those that you see with severe initial neglect are more likely to still be having chronic neglect. It doesn't occur in isolation, both in terms of other cognitive deficits happening at the same time, but also in terms of other brain health markers happening at the same time, and protective factors such as cognitive reserve all impact neglect. And then just to leave you with a bit of food for thought, you will have noticed I didn't mention interventions for neglect, and that's because in the current literature, and all the Cochrane reviews, you will find that the evidence is not enough evidence to recommend any particular intervention. That's also because most of the current literature has got very underpowered, unselected cohorts who all improve, but the control condition often also improves. So there's a current large trial going on, the SITE trial, which is probably one of the first to do multi-center intervention for neglect. But there's questions to be asked, right? Should we be including everyone? Should we really be focusing on the severe cases? What about the brain health markers and all the co-occurring deficits? That's it. Thank you very much.
Thank you, Professor Demeyere, for a fascinating talk. We have time for 2 questions. Yes, Professor David.
Hi, thanks very much. Very interesting talk. Just to go back to Marshall and Halligan, I think it hinges on what you describe as neglect, but the individuals were still, in quotes, neglecting the left side of the picture, or you could say were just inattentive to that. So but the principle is still there, that you can fail to notice, let's say, aspects of a visual scene at one level, at sort of a conscious, expressive level, but still process information of a more emotional kind at a different level. So in a way, you vindicated their study. I mean, did you try and cue the people to that side of the space? I mean, did they say, oh yes, now I see the flames?
No, because of the way the registered report was set out, we were very, very regimentally locked into what we said we were going to do. So there was very little space for that. Probably the thing to note when we say the people with no neglect showing this kind of bias, we didn't specifically choose a side for them. So if we found no neglect in any of the cancellation tasks, we actually, the way that was presented was both on the left and the right, the issues. So this very strange, them saying it's the same, wasn't systematically lateralized. It was to either side. So that was the completely crazy bit that probably didn't emphasize enough. But so it wasn't that the patient with no neglect still had this kind of leftward bias. It was both sides. Yeah, but yes, it would be cool to ask extra questions, but length of testing was already a problem actually in our acute setting.
Akshay.
I just, out of curiosity, as they recover, do they become more aware of the problems they've had, or when they look back on it, were they aware that they were missing a part of the world, or as they recover, they know they're improving, so to speak?
Yeah, so I mean, like the video, so Jo knows she is missing things. Like she is aware that she has this problem, and that so definitely as people become more chronic, they are usually aware that they have this issue, and they try effortfully to monitor, but can't quite make it. So yeah, their awareness definitely improves, whereas in the acute setting, you often have to explain that they have this thing that they just don't understand what you're explaining to them. So that insight definitely improves loads. Thank you.
Thank you very much. I'm mindful there's many more questions, but perhaps if you could approach Professor Demeyere at lunch in view of time.